So welcome everybody. It's another Friday in the summer, and I'm glad to see you here. I think this could be an interesting topic just because with the changes that I think most observers are expecting in Medicare and the Medicare Advantage plans, it's going to change the calculus that you use to decide whether someone who is on Tricare should also have a Medicare and MA only, or if someone is on VA or on federal employee health benefits. Sorry about that. So today I am going to be doing the presentation here. And if you don't mind, I would like to hear some of your experiences. For example, I know that Colette has had quite a few things, has quite a bit of experience with people who have dual coverage or triple coverage. I imagine that some of the other people who have been doing this quite a while are the same thing, like Helen and Beverly and Bill and Craig. And so I would love to hear what your experiences are. A lot of this is going to be intended to persuade you to revisit how you have made decisions in the past. So I'm hoping that you'll go, okay, in the past, it was always a slam dunk. If they were on Tricare, I'd put them onto an MA only plan so they would get good dental or good something like that. Now we're going to have to start looking at that a little bit more closely. And I don't have a formula that is going to be, you know, it'll make the good decision for you every single time. But I'm hoping that we can have conversations today about what's going to happen. As we're going through here, we're going to be talking about, obviously, the intersection of these four federal plans, these four federal coverages. This is a CE. That means there have to be questions. The questions are going to be emailed out to you by Morgan at the end of this. And what I would like you to do is encourage you to pay attention to the orange text when you see orange on the page. The orange means that it's going to be in a question. If you see yellow on a page, that means that I'm trying to put an emphasis on it because I think that it may mean that you're going to make different decisions starting in 2025 than you've made in the past. And so that's what those things are today. I'd like to talk about these three types of coverage that can coordinate or exist alongside of Medicare. And the first one is Tricare for Life. And I think most of you have a pretty good understanding of that, but we are going to go over some of the things just to remind you, because when you're not dealing with it day in and day out, some of the niceties sort of go away. We're also going to be looking at VA coverage, and then we're also going to be looking at federal employees' health benefits. I bring this up because I don't know many agents who actually put people who are on the federal employee health benefits on MA and keep the federal employee health benefits, but I do understand that some people have had good experiences doing that. You may hear people talking about Tricare Prime or Tricare Select. Those are coverages for people who are still on active duty military. So we're not going to be talking about either of those today. I would like to point out here that Tricare is not just for military people. It is Nancy, I'm glad you're monitoring that. I can't monitor I don't have enough real estate to monitor the chat, so appreciate your monitoring that. The Tricare is for retired members of the uniformed services. And we're going to look at what the uniformed services are in just a minute. I think that you may be surprised about what the uniformed services are. This does not mean that someone is an officer, someone is enlisted, or anything like that. This is someone who has to wear a uniform because of the branch of service that they belong to. And there are more uniformed services than I think most people are aware of. I'd like to talk a little bit about the Veterans Administration coverage. We're going to look at it from a high perspective right here, and then we'll get to more details in just a minute here. But this is so Tricare for Life for people who have retired from the military and then have Medicare Part A and B. And if you have Tricare coverage and then you have an activated Medicare Part A and B, then you automatically have Tricare for Life. VA coverage, it's complicated about who qualifies, and you guys are not going to have to worry about who qualifies for any of these programs. So it's not like when you are working with people who are on Medicaid, and sometimes you have to help your Medicaid beneficiaries navigate the paperwork, the red tape that's associated with those programs. Here, they all have resources that are going to help them get into fill out the application paperwork and everything for them. So you don't have to worry about that. But you do probably have to be aware enough of the eligibility rules and everything that if you encounter people and they ask you questions, you can come off as credible. And that's what we're trying to work on today. I do want to point out that FEHB is probably something that most of you have not done much with, and you probably won't do much with it, and I'll show you why. Though, like I say, I do believe that there are some agents here that have had good good experiences with having people on federal employees' health benefits and on Medicare. Okay, so let's talk a little bit about the uniformed services. And I think this could be a surprise for some of you. So on the left column, there are probably the list of uniformed services that most of you are expecting: Army, Navy, Marines, Air Force, and Space Force. That is, again, I think I mentioned that is both for enlisted and for the officer corps. But then there are some, excuse me, some unexpected parties who are also part of the uniformed services. And these guys actually have Tricare. Jeez. I'm going to turn my phone off. Anyway, so some of these are the Coast Guard, and that's probably not a big surprise. But let me mention a couple of these other ones, and you may encounter people who are in these fields, especially as now we're all more aware of COVID-19 and what that done. One is the Public Health Service Commission Court. And the interesting thing here is you can see that I have in parentheses HHS. That means that the agency that oversees CMS, that's near and dear to all of our hearts, also has a uniformed service corps, and that's the Surgeon General. He is the leading officer of that particular branch of the service. The other one is NOAA, the National Oceanic and Atmospheric Administration. They have commissioned officers, so they don't have any enlisted. in this branch. The guys who wear the uniforms are guys who fly planes into hurricanes, or who go into, natural disaster ravaged areas and help with that stuff. And then also the reservist and National Guard retirees, starting at age 65, are considered uniform service. Were there any surprises there to any? No?
Doug, if I could just interject one thing.
Sure.
You already mentioned it on the previous slide, but I think it needs to be expanded just a little bit. The Tricare is the word that people hear all the time and use all the time, and Tricare is utilized by many people in the military, but then there's an advanced section referred to as Tricare for Life. Those are two different things. The Tricare for Life is once you are eligible for Medicare.
Yes, thank you, Gene. So there are people, and you may encounter people who are on Tricare. If they go out of the country, then Tricare is the only thing that covers it. If they have Medicare Part A and B, and even if they have a Medicare Advantage plan, if they go out of the country, then Tricare is the only thing that covers that. You might want to keep that in mind. This little table here, I think, is really pretty interesting. It shows how Tricare and Medicare coordinate, and this is original Medicare or Medicare Advantage, and most of the time, and certainly in the past, and though I think that this will continue in the future, when people want to put, and I'm going to repeat this several times because I spend quite a bit of time working with agents who get caught by this. Most of the time, if you have someone who has Tricare and they want to get on a Medicare Advantage plan, it's usually for the extra benefits. It is not for the drug coverage. The drug coverage with Tricare for Life and Tricare in general is richer than the standard prescription drug coverage that comes with the Medicare Advantage plans. And so you normally want to put them onto an MA only plan so that they can get the dental or the vision or the hearing or the ski pass or whatever it is that you're trying to enable them to get to. But the core benefits, the core health benefits, those are pretty comprehensive in Tricare, if that makes sense. So you can see here we've got several columns here, and what they're trying to say is, and I'm going to dwell on this. There are certain slides here that I'm going to throw them up, and I'm not going to really go over them. I'm just going to expect that you're going to be looking at those slides and sort of consuming what those slides are about. This one I would like to actually look at here. So if it's covered by, let's look at that top row. If it's covered by Tricare and Medicare, Medicare pays first, and Medicare pays the allowed amount, and then Tricare pays the remaining amount, and you as a Tricare beneficiary pay nothing. And that is how most of the things works. So let me just give you an example. My mom is actually a Tricare for Life beneficiary, and she just recently had a fall, and they put her into a facility, into a skilled nursing facility, and she is on United Healthcare, and they pay, I can't remember exactly how many days, I should know how many days they pay, and then they said, now after so many days where we pay 100%, then you have to start paying a copayment of $204 per day. They decided to keep her in the skilled nursing facility, and Medicare stepped in and paid that complete copayment for her, which is really a nice benefit. If the service, second row, if it's covered by Medicare only, the ski pass that I think of, sort of like yes, and they're $1,200. Then Medicare pays, and obviously Tricare pays nothing for that. Covered only by Tricare, then Medicare doesn't pay anything, and the Tricare allowable amount is covered. The Tricare deductible and cost share are there. Most of these deductibles and cost share occur if you are outside of the United States. There is very little deductible and cost sharing occurring inside of the United States, other than Medicare Part B, and you may also have a Medicare Part A premium that you have to pay. So they're trying to cover their bases there. If it's not covered by either Tricare or Medicare, then nobody pays anything. Any questions on that? Is that table helpful?
It is. I just would like to mention something with the Tricare. What I've run into, if they have Tricare, then sometimes, depending on the doctor or facility they go to, there is a claim that on the secondary where the doctor will bill, like let's say the Medicare or the Tricare, and not bill the secondary. So sometimes they have to file their own claim to get that reimbursed, if that makes sense, or to get it to go through the system. So there are forms that you can help your beneficiary get to fill out to get that reimbursement in case that does happen.
Can I just follow up with that, Colette? So what you're saying, okay, so here's the way the system is supposed to work. If you have Tricare and you have a Medicare MA plan or something like that, you're supposed to be in a particular database. And if you're in that particular database and it goes to the Medicare Advantage carrier, the Medicare Advantage carrier is supposed to pay, and then they are supposed to automatically forward that on to Tricare to be paid. What you're saying is sometimes that doesn't happen.
Correct. Yeah.
I think that's right.
Okay. Yeah. So there is a form that they can fill out, and Tricare does have it on their website where they can submit for the claim for reimbursement if that happens. I mean, I don't think it happens very often, but I've ran into it over the years.
Okay. Well, thank you. Always appreciate your experience.
No problem.
Okay, so let's talk a little bit about some of the things that Medicare agents should know about Tricare for Life, right? Just sort of the things that you have back in the back of your mind if you encounter people like this. One of them is that there's no normal enrollment card into Tricare for Life. So you can't say, hey, let me see your Tricare for Life card. They have a Tricare card and they have their Medicare card, and if they have both of them, Part A and their Part B is active, that means they have Tricare for Life, if that makes sense. And I mentioned a second ago when I was talking to Colette, they have this DEERS database. You can see that there. And that stands for Defense Enrollment Eligibility Reporting System. That is how they know who is, this is how the coordination occurs between the two systems. Medicare Part A and B are mandatory. And if you get it and you already have the military ID, then that is a loan qualification for Tricare for Life. And I think I've already mentioned this, but Tricare pays after Medicare pays. Tricare covers the Medicare out-of-pocket costs such as deductibles and coinsurance, like going back to my mom's story. There are a number of gotchas, and over the years, I have spent quite a bit of time with these gotchas. So agents don't know about them, and so the agents end up doing things that they regret doing and wish that they could go back and undo. So let's talk a little bit about these things. The first one is that the primary reason that people get into Tricare, and I've already mentioned this, is that they are looking for the extra benefits that come with the Medicare Advantage plans. Now, those extra benefits, they are predicted to be declining dramatically this year, which means that you may not want to recommend to people that they get into an MA only with their Tricare. You may want to. I'm just saying it's not as clean. It's not as it's not a no-brainer the way it's been in the past. One of the things that happens when you get people into these MA plans, and the MA plans then become primary, right? It becomes primary, the co-payments become primary, the provider network becomes primary. And I have had agents who have explained this over and over to the beneficiaries, and the beneficiaries just don't listen. And so now all of a sudden, they have to do what the Medicare Advantage plan tells them that they have to do. And they were believing that what they had to do if they now have an MA only plan that has good dental is they would just get that. They would keep using the Tricare the way that they've always used the Tricare, and that they would just be able to go to the doctor, to the dentist, and have the dental work done, and then the MA plan would pay for that. And it's not that easy. What happens is they get into a MA only plan. The MA only plan now has a provider network. They can only go to the people in that provider network. They now have co-payment to make those co-payments and everything for these things. And it is, and this could be one of the things that Colette's talking about here, right? So if you make a co-payment, it should just go to this into this DEERS database, and it should be paid automatically by Tricare, and sometimes it's not being paid automatically by Tricare. The best way to consider or to view Tricare for Life is it sort of operates like a Medicare supplement. And when I say it operates like a Medicare supplement, I don't mean that there's any premium that has to be paid. It operates. It doesn't have set features and everything. What it does is it simply pays after the Medicare Advantage or the original Medicare pays. It comes in and pays the cleanup, sort of the way that a Medicare supplement does. So I don't want to emphasize that analogy too much, but that's what happens. You know, it's sort of like being on a plan F, where it just pretty well, if you're in the United States, it pretty well just covers everything, and it does include prescription drug coverage. When you hear this stuff, you'll often hear that the Tricare for Life is a Medicare wraparound coverage. That's wraparound. It's sort of like a Medicare supplement. It sort of encases and covers it. The RX coverage is generally superior to the Medicare drug coverage. In other words, it is creditable. And notice that is in orange there. That is why if you enroll someone in, this is probably the thing that has caused the most harm to enrolls on a MAPD, and that MAPD drug coverage replaces and kicks out the drug coverage that they have with Tricare. And that all of a sudden they realize that they're paying more for their drugs and everything. That's not what they intended. They get pretty upset. And so in yellow, notice, therefore put them on MA only plans, because the prescription drug coverage for Tricare is higher quality. And then I have mentioned also the provider networks and the expectations of the Tricare beneficiaries are incompatible or incongruent with the expectations of your other Medicare Advantage beneficiaries. They know how it works. Their expectations were not set by Tricare, and so they're not upset when they run into restrictions on who they can go and see. So if you're in Tricare for Life, the network consists of all Medicare participating providers. And I think I know I was talking with Gene before this meeting, and he was saying that there are a number of providers who are unhappy with the Tricare reimbursement rates, and they're pulling away from it. That seems to be a theme that is occurring across the industry. Our carriers and our providers are becoming less than enamored with the Medicare Advantage plans. They are becoming less than advanced. They don't like how the insurance carriers are trying to reduce the insurance carriers' payouts to the providers. And so there is going to be, and it started last year, and it is more fraught this year than in my entire period in Medicare. Providers and carriers are really coming to blows, and I think it's going to get worse. The MAs have, and let me explain this. I just want to do this. So if let's say that you're in Salt Lake County and you have TFL, that means you can go to approximately 97% of the providers in Salt Lake County. But if you are in an MA plan, they have a contracted network, and it is usually a subset of the Medicare participating providers. And all of you run into this where you talk with someone and they say that they have been going to their provider and he's accepting Medicare and everything, and you're going to put them in United Healthcare or Humana or whatever it is, and you look them up in the provider list and they're not there in the provider list. So these MA plans are smaller. They are contracted compared to the Tricare for Life. And it is quite a shock when a Tricare for Life beneficiary believes to just add benefits. They don't have any restrictions. All of a sudden, they want to go visit somebody that they've visited all the time on Tricare. And now that person, that provider is not part of the MA only provider network, and now they can't go, and they get upset, and they talk with the agents, and they're not very happy with them. Anyway, those are the three gotchas that seem to be. Those are the ones that I've spent most of my time on. I'm interested. Have any of you other guys? Have you guys run across different issues with this? It's a quiet day. Okay. Let's go on to VA eligibility. And I don't want to go through all these priority groups. I believe that I just see Barbara's note here. Correct, Barbara, that's correct. So the only way that Tricare would take first place is, and I don't know if all of you can say this, but she says, so if a person goes to a provider that isn't on the MA plan, then Tricare won't pay anything either. And yes, there may be an exception or two to that, but generally speaking, that's the way it is. Medicare becomes first care, and Medicare pays, and then they forward that over to Tricare to pay for the outstanding copayments that are a reflection of the MA plan. So I just wanted to have you guys look at this, and I want you to notice the one in orange, the priority one group. These are people who have 100% disability, they're unable to work, or they are Medal of Honor winners, recipients. And I am going to, as you're looking at this, let me just let me expand some of these acronyms. POW, most of you probably know, stands for Prisoner of War. So that's what that is. Purple Heart is given to people who are wounded in the line of duty. So that's what that is. I did want to point out that priority group 7 and 8 are the equivalent of a Medicare Advantage plan. So if, and that means, and what I mean by that is when they go, they commit to, they sign a contract to pay co-payments, and those co-payments are quite, they're equivalent to the Medicare Advantage co-payments. And so there's really very benefit, at least from an economic point of view, if you're in priority group 7 or 8 of going to the VA. When you are in the VA, they are uncoordinated plans. And if you want treatment from the VA, you have to go to a facility and visit a VA doctor, and there's going to be no communication between VA and the MA plan. Eligibility requires that you are in the service on active duty for 24 months and that you were not discharged dishonorably. If you were wounded 24 months or up, then you also qualify for these things. Any questions on these priority groups or anything like that? My goal here is simply for you to recognize that when you are talking with a veteran, there are all sorts of complicated things that you probably are not aware of, depending on where they are and which priority group they are and which level of service they're getting. And I just wanted you to be aware of that. Okay, let's talk about what Medicare agents should know of VA coverage. And the first thing, and I've already mentioned this before, is that they are completely separate channels. You can be a member of both plans, but there's no coordination. The VA doctors do not know what the MA doctors are doing. The MA doctors don't know what the VA doctors are doing. There's no coordination at all. Congress can cut off funding for the priority group 7 and 8 at any time. Veterans must go to the VA facilities for appointments, so the big hospital up in Salt Lake, and there's some smaller clinics that are now around. The big thing about VA care is that it is kind of inconvenient to have to go to a VA facility. So if you were to have to go into the hospital for an operation, you would have to go, and I may be wrong, but I believe that the only place that you could go is to the big VA hospital in Salt Lake City. And anyone can correct me if that's wrong. It's inconvenient because there are not enough specialists. And by the way, there's not enough specialists in civilian life either right now. There are long delays for appointments and treatments. There's poor communication between patients and staff. There's poor access if you live in rural areas, which is just like the MAs. But there are more bureaucratic hurdles if you're or surgeries or everything, right? It's not nearly as simple as it is in for an MA plan. Any questions there?
Doug, I just wanted to make a comment. When you said that you have to go to a VA facility, I've known a couple of people who were able to go to a different hospital. It was just outsourced. VA still paid for it, but they went to University of Utah.
Yes. So what happens is the VA sometimes, not sometimes, frequently do not have the resources to handle what they have to do, and so they outsource. Yeah. So that's a great clarification. Thank you very much, Alexius. Here's something, and I've talked with several beneficiaries on this. So because they're VA and MA are completely separate channels, lots of veterans say, I don't even use Medicare. You know, I don't use original Medicare. I don't use Medicare Advantage. Why should I have to pay Part B premium? And they're right. You don't have to have Medicare Part B premium for Veterans Administration. And if you only use the Veterans Administration, then you could be asking yourself, why do I need to pay a Medicare Part B premium? And the reason is because the law says that you have to pay for it. So you just have to explain to the people that you're talking to that they still need, even if they're going to the VA, they still need to pay their Medicare Part B premium. The primary reasons for having Medicare Advantage, again, is convenience. It has been in the past easier to get into specialists, to get into treatment facilities and everything. It has been to wait for the resources at the VA to free up so that you can get in. So the waiting periods are generally shorter in civilian life than they are in the VA system. Though, and you can see I've got two ouches here right underneath it. The scarcity of providers is starting to hit our civilian life. We don't have enough specialists. You want to get into a specialist, and it's not infrequent to have to wait 3 months to get into a specialist, even in civilian life through Medicare Advantage. And then we are also living in a time, and I think most of you have heard me talk about this, where we just had this huge cyber attack, and it's affected at least a third of the healthcare system in the United States detrimentally. And so what we find is in a situation, in circumstances where we already don't have enough physicians, we already don't have enough hospital beds, all of a sudden, because of this cyber attack, which disrupted the payment system, all of a sudden physician groups are they're offering themselves up for sale. I don't know if you've noticed, even around Utah, you see physician groups that are offering themselves for sale. It's all part of this Change Healthcare cyber attack. And hospitals are actually laying off employees as well because of the problems with the payment system. Any questions there? Any comments there? Gene, can you take this?
Yep, just had to turn on my microphone. So I wanted to touch real quick on a couple of things here with the CHAMP VA. In one of Doug's earlier slides, it talked about the fact that there's a lot of confusion and complexities about who belongs in what group, and if you're overseas, or if you're disabled, or if you've lost a member. Anyway, there's a lot of different rules and regulations that decide who gets to go where. It's not necessarily important for us to understand all of those things because they don't all intersect with Medicare, which is what our focus is. But it's good to know what those are so that if somebody mentions them, if it comes up in a conversation, you at least have enough of an understanding that the conversation can continue without you feeling like you're out in the left field somewhere. So I wanted to point out real quick on the Tricare, if you're under 65, there's two major programs. One is the Prime and one is the Select. One of those is similar to an HMO, that's the prime, and one of those is similar to a PPO, which is select. So if you and your family are in the military and you're under 65, then those are plans that you have as options to sign into. CHAMP is another option that you have to get into, and you qualify for CHAMP if you become a widow or widower, your surviving spouse, and your children. The children are usually available to be on the military plans if they're under the age of 21, and if they're in school, then it goes up to age 23 or until they graduate from college, I guess, whichever of those comes first. And so if you are the child or the surviving spouse of a permanently disabled or deceased veteran, then that's where CHAMP VA comes in, and it's an opportunity for you to have coverage that is similar to what you can get under the Tricare coverage, but it's for the VA eligible folks. The folks, when they get to the age of 65, again, they must enroll in Parts A and B, and by doing that, those are the things, just like in regular Medicare, you have to have Parts A and B because those are the supporting structures for the rest of the plan. Again, it's a secondary payer. Once you qualify for Medicare, it's considered credible coverage, and it's going to replace the Medicare Part D drug coverage. So, you know, you've got drug coverage through CHAMP VA if you are that surviving spouse. CHAMP VA patients can also enroll in Medicare Advantage plans, again, like similar to the wraparound that they have in Tricare for Life. Generally, you're going to look at an MA-only plan because otherwise you've got duplicate coverage that you don't need to be paying extra for. Okay, next slide. Cost sharing is excellent, $50 per year for outpatient coverage, 25% of the allowable amount until your maximum out-of-pocket hits $3,000. So your max per year is quite a bit lower, substantially lower than on an MA plan, and you pay 25% as you go along until you hit that point. It does coordinate with other health insurance coverage, and you're generally going to go to non-VA providers. Those resources at the VA are obviously scarce, like Doug's already talked about, where outside of the VA, you've got more options available to you. Again, motivation to enroll in an MA plan are for the extra benefits, dental, vision, and hearing, and the convenience of having access to doctors and hospitals and so on. We probably will see an uptick in people, if you're not already looking at it, the dental, vision, hearing plans, like GTL, or some of those are plans that we're probably going to see more of this coming year as plans get whittled down to stay within their budgets. Okay, I think that's it.
Thanks, Gene. Okay, so we're closing in here on the home stretch. Colette, I was going to talk with you before this meeting, and I never had a chance. Did you have, well, what I'd like everybody to do, I'd like, Colette, I think I should confirm this with you. Did you have a story of FEHB and Medicare Advantage coordinating well and beneficially for people?
Yeah, it happened with my uncle. So my aunt was actually a nurse with the VA hospital, and so they had federal benefits. And when she passed away, they basically put me in charge over my uncle if he can't make his decisions for him. So he was in a trike accident in 2020. He goes into the hospital. They never wanted to change anything because they were always on federal, always covered really well. And so he ended up in a skilled nursing facility for 103 days. And come to find out, the skilled nursing facility called me and they're like, okay, he's ready to be released. You can pick him up at this time, but bring $12,500 check with you. And I'm like, okay. He has federal benefits. And I really didn't go through him. I didn't look at him, because he just was like, oh, they've always paid very well. So I take the check down for $12,500 because, of course, I'm the executor and everything and pay all of it. So he was pretty upset that I had to pay that. And so I did some calling and research. And I was like, well, maybe it's just the federal Blue he's on because they went with Blue Cross Blue Shield. Come to find out, he was paying $603 a month, which was the same rate monthly he was paid when my aunt was still alive. So even like they still have to pay the self plus one if the one passes away, the one that is like the policy holder. So that was a huge deal. So that was coming out of his checks. And then on top of that, they only covered the 30 days in a skilled nursing where the Medicare covers days 1 through 20. So technically they're only paying 10 days of that skilled nursing. And then that he was in the more expensive plan. There is like a basic plan or something like that where they don't have no coverage on skilled nursing with the FEHB. So we ended up putting it in a Medicare Advantage plan because he didn't ever want to be in that situation again. So the next year, because he still had some surgeries to go through and all that, we put him in an MA only. Then he hit his max on the MA only, which was only like around 4,500, if I can remember right. And then the year after that, he decided, which was this last year, he decided to get rid of federal Blue altogether because of the fact that he's paying so much per month and it keeps going up, where it didn't make sense. So, I mean, he hasn't even come close to his max out of pocket this year on the Medicare Advantage. So I did the MA only for the first couple of years, and then we moved him to an actual MAPD this last year.
Okay, thank you. So that sort of goes with what I'd like you to notice about the FEHB coverage, and look at the large bullet, the second from the bottom. It says one pays the same premiums in retirement as active, and Colette did use these terms here. So the monthly premiums, self-only is anywhere from $588 to $817. And self plus one, your spouse, that's anywhere from $1,271 to $1,765. And so most agents look at this and say, you would be better off just to be on a Medicare Advantage plan. Just stop paying those large premiums and just go on the Medicare Advantage plan. Colette did sort of point out that there is a case to be made where if you, there would be very few cases where this would work out, right? Where you would want to say, I'm going to be better off paying the premium so I get double coverage, in a year where you have just a lot of stuff going on, rather than being in a Medicare Advantage plan and having to pay, $6,000 or something in deductibles or co-payments or cost sharing. Notice that $500 a month that exceeds the $6,000 that you would have to pay. So in most cases, you're going to say, well, it's just not worth remaining on FEHB. FEHB is, and you'll hear people, and I've heard quite a few people who say, you know, I worked my whole life to get this, and it's a benefit that I've earned, and I am going to keep my benefit. And they continue to pay this because they think it's this great benefit. But it's really not. But sometimes it's just really hard convincing these people otherwise. If you are on this, and go ahead.
I was going to say what I've run into, they don't know. They really don't know how much they're paying. Like my uncle just honestly did not know. The ones that I've run into, it just comes out of their retirement. They don't realize that it's gone up. They really never can do it. They just think that they're getting it, they're getting it for free, until you really show them, no, this is what you're paying. Where is your paperwork? They don't look at that and see that that's actually coming out of their check and their annuity.
That is, I've never looked at that. Thank you. That's pretty helpful. So maybe when you're talking to people, and these people, yeah, go ahead, Alexis.
Well, I want to agree with Colette. My parents both retired from working at the Defense Depot. They had the FEHB, and it wasn't until I was going through their retirement stuff, they thought they were getting it for free, and they were paying a fortune for it. So I moved them over to an MA plan. Yeah.
And so that's what the opportunity here is for your beneficiaries, right? Is to leave this plan that has very little value in it, and yeah. And so you'll see in that third bullet from the bottom, but there's no genuine value in this. So it coordinates with Medicare, and you can get it so that Medicare pays first and then this pays afterward, but the premium just completely offsets all the value there. So most of the time, if you're like Alexius or Colette and you run across people like this, you know, it's going to be I was making the assumption when we started in here that most of these retirees actually knew that they were paying the premium, but it sounds like there's a good chance that they don't know that they're paying the premium. And the reason is, and you see that in the third bullet from the top, there's that word annuitant that is in parentheses there. That's what these guys are called. They have a lump sum of money, and they are paid this annuity, and it looks like that these healthcare premiums are subtracted from the amounts that they're getting with their annuity. And so you can really increase their take home every month, if you will, by moving them over to Medicare Advantage plans. Yeah.
Well, one thing I do want to mention, if you, Doug.
Go ahead.
Oh,
yeah,
I was just going to say a good way, if you do run into this and somebody's like nervous about it, there is a way to put it on a suspend status. So they can actually suspend their federal benefits and pick it back up. It was like a 2 to 3 year, you can do it. So you can basically suspend it, and then they get that money every month. So that way they can re-enroll if they absolutely want to. And that's a workaround just to get them into it, to try it.
Yeah, the emotional runway. Yeah, I like that.
Yeah.
Thank you. So let me sort of circle back around to the point that I made it up at the top here, which is that 2024 is going to be a watershed year. I think that, and most of the people that I'm reading, the financial analysts, the carriers themselves, CMS people, they are all saying that the nature of Medicare is going to change. And here are some of the reasons that it's changing so fast. The administrative changes, like the final rule that I think I'm anticipating that will be out on Monday. We'll be able to look at that, even though we had previews for it. This is where they're talking about the increase in compensation for agents, both on PDP and MA, but also some of the restrictions that you'll no longer be able to do the health risk assessments, things like that. You'll no longer be able to talk to carriers and try to persuade them to pay for some of your marketing costs. There's also the RX coverage. They're eliminating the donut hole. And so now there is going to be, with the 2025, and I'm sure most of you know this, there's going to be a $2,000 maximum out of pocket for the prescription drugs. Most of the people who are looking at this are anticipating that the premiums for the PDPs are going to rise rather substantially because there's not a safety net in the PDPs the way there is in the MAs. And that is going to probably persuade quite a few people who are on Medicare supplements with PDPs that it is no longer a good use of their money. So there is anticipated more change that's going to be going over into MAPD. And this is at the time where, and I've mentioned this before, where the conflicts between the MAPD carriers and the provider networks are really ramping up. There's this attack that has threatened the financial stability of a number of the major carriers, as well as physician groups and hospitals around the country. There is an increase that started fourth quarter of 2023, where Medicare beneficiaries are utilizing services at unprecedented rates. So during COVID, they stopped using it, and it was sort of the carriers were really enjoying profits, and now everybody is going back and trying to get everything taken care of that they put. And so the carriers are struggling there. And then these escalating conflicts between carriers and providers, a lot of this has to do with the artificial intelligence that is coming out. And I just wanted to, I guess here's the takeaway for me. The takeaway for me is that this AEP coming up could be more stressful than any of the AEPs that you've had in the past. There will be more people changing, more people upset, more people seeing the value of their plans go away, the extra benefits go away. So you may want to say, well, I need to have, and I think it was, I can't remember, I think it was Gene that mentioned this. You may want to have, you may want to pay more attention to the standalone DVH plans, dental vision hearing plans. You may want to revisit how you make decisions regarding these other types of government coverage. It's going to be a learning time, and we want to help you. And I want you to know that you can call and talk with us, talk with me, talk with Bob, talk with Morgan, talk with Nancy, anytime. And we would be willing to help you sit down and figure out how you're going to manage the greater demand probably on your time and services this year. So we can probably come up with some stuff. So please feel free to reach out to us and talk with us.